start. This is a 55-year-old female patient presented with left eye swelling, pain, and proptosis.
Okay, so I'm presented with CT scan of the brain, axial cuts. For a 55 years old female with left eye symptoms, I would like to have a general look before starting my comments. So, yes, I would like to concentrate on the region of the globes, given the history and the complaint. So the left globe shows mild increased preseptal soft tissue thickening. No, the intracorneal fat is clear. The intraocular muscles are intact. There is no masses, no focal lesions, no collections. The eye globe is, the orbit is unremarkable. So the rest of the brain shows no abnormal lesion, no hydrocephalus, no midline shift or massive effect. In my routine practice, I will check the bone window and the other planes like sagittal, coronal. Okay, so in the bone window, there is extensive opacification of the left maxillary sinus. I think there is mild proptosis, yes. Yes, the left eye is shows mild proptosis, and there is soft tissue air in the preseptal space. Again, extensive sinusitis of both ethmoid and right sphenoid and minimum left sphenoid mucosal thickening. The right maxillary antrum also shows mild mucosal thickening. The left maxillary antrum shows bone erosion and thinning. The left nasal cavity is also opacified. There is no hyperdense lesion foci within this mucosal thickening. So my differential till this point is extensive sinusitis with orbital cellulitis, given the air within the preceptal space. This could be fungal. I would like to compare with the previous, if any, if available, and proceed for MRI for further characterization and assessment.
Do you have
Yes,
any
and to
clue
check for
here?
intracranial.
Yeah, yeah. Do you have any clue here in this CT, either this fungal or not?
Okay, in this CT, it is not typical fungal to me because I couldn't identify the hyperdense hyphae or the fungal balls, which are usually hyperdense in the CT.
Okay.
So it is just, yes, it is pansinusitis with left orbital cellulitis for urgent ENT and ophthalmology referral, for MRI for further characterization and to exclude intracranial extension and follow-up.
Okay. This patient, after 2 days, he did a follow-up CT. What do you think?
Okay, so this is the CT brain axial cuts for the same patient 2 days later. It shows abnormal, yes, density in the left parieto-frontal lobe in form of hypodensity. Yes, with loss of corticomedullary differentiation of the left parietal lobe. Again, hypodensity at the temporal region and the frontal lobe. So much concerned about extension of the infectious or inflammatory process into the brain parenchyma given cerebritis. I would like to check the rest of the brain, advise for MRI to exclude any abscess formation or yes, infected subdural collection, and to look for the bone window, to look for any bone breach.
Yes.
Yes,
So
so
what is
to
your
me, these
next
are
steps?
multiple CT with contrast or MRI.
Okay.
Okay, so this is MRI for the same patient. This is T1.
Yes.
The region of concern. Okay, again, seeing the abnormal sinuses
Yes.
appearing hyperdense on this T1.
Mm-hmm.
So I would like to check for the T2 because if this is fungal, I will see the pseudo-pneumatization of the sinuses on the T2 weighted images. So there are areas of signal void.
Yes.
Yes, so I'm concerned with the fungal sinusitis, given these appearances. I would like to check the brain. There are multiple focal areas of increased T2 signal intensity in the left frontal, parietal, and temporal lobes. I would like to, yes. So these are the suspected areas of cerebritis. I would like to correlate with the post-contrast and diffusion images.
This is post contrast.
No definitive enhancement.
What do you think?
Okay,
Hello?
so
Yeah, what do you think?
yes,
Hmm.
yes. So to me, yes, again, this is cerebritis, complicated sinusitis, panfungal sinusitis, complicated by cerebritis
Yes.
for urgent neurology and ENT referral.
Okay. Look here at this one.
Yes, and for ophthalmology as well, because of the, yes, left glove cellulitis
What do you think?
as a complication as well.
After 2 weeks, what do you think?
Yes, the brain presents lesions showing peripheral rim enhancement, denoting abscess, multifocal abscess formation. I would like
Mm-hmm.
to check for the sinuses to exclude any associated sinus thrombosis, which is a known complication, and to look for associated meningitis as well. So, uh, yes, so involving the anterior and posterior cranial fossa, looking for any infected subdural collection as well. There is associated meningitis. Yes, there are multifocal cerebral abscesses.
Is this patient underwent any intervention?
Yes, yes, there are bony defects seen on the left.
Where is the left eye?
Yes, it is not there.
Yeah.
The left
So
eye and the
this
left
is
sphenoid bones are there. So
status post-operative.
inoculation.
Yeah.
Yes,
So what's your final diagnosis?
for ex
Final
so this
diagnosis?
is extensive. Yes, pansinusitis with orbital cellulitis and multi-brain abscesses.
Excellent. What type of fungal sinusitis do you know?
Okay, the worst one is the invasive, where there is
What
extension to
else?
the brain and the
What,
orbit.
what else?
There is the non-invasive and the fungal ball
What else?
and the semi-invasive.
What else? Last one. The most benign one.
It's the non-invasive, semi-invasive, invasive, and fungal ball.
Not
Aspergilloma.
non-invasive. Allergic.
Allergic,
Allergic.
sorry, allergic, yes.
Okay. Thank you, Dr. Naram, so much. You did very, very well. This is the answer. What happened here? It was a case of invasive fungal sinusitis. Already we have three types of fungal sinusitis: allergic, which is the most common, then semi-invasive, then the invasive. Fungal boil, this is, I think, chest CT or X-ray finding. What happened here? What happened? It was very few subtle finding here. If you see here, just here in the preseptal and the eyelid thickening here, and beside it, here there are some soft tissue. I think in bone window more obvious here. and two fossae or few fossae of air. Okay. When she asked for bone window, because in here in soft tissue window, you can't detect well what happened in the sinus. So she did very well when she asked for this bone window. The sinusitis is very obvious, very marked, but our doctor depend only on the hyperdensity of the fungal hyphae or metal to rule out or to prove the fungal sinusitis. Despite there are no obvious CT hyperdensity, but there are obvious bone erosion in the medial wall. Look, Dr. Naam, look, bone erosion, especially
Yes,
in
sir.
the medial, this one, very large. Compare with the other side, compare here, okay? Bone erosion. So bone erosion here and rarefaction. Rarefaction means thinning out. So there are at least some evidence of fungal sinusitis here, invasive type. Sure, we should rule out intracranial extension through coronal and sagittal, but we don't have MBR in radiology. The other finding here, in contrast, look at this superior ophthalmic vein, compare with the other side. There are non-enhancement here. So there are a doubt, big doubt or an evidence of thrombosis here. When you see any evidence or any doubt of superior ophthalmic vein thrombosis, look at the sinus here, cavernous sinus. If you compare right with left, here we can see only the carotid segment, but around it here, you can't detect any enhancement. Okay, is it clear? Compare. See, only we see this enhancement which represent the carotid segment, but around it is black. In comparison to here, you can't differentiate the the ICA, internal carotid segment, from the sinus. Why? Because the cavernous sinus is enhanced. So this is another evidence of invasive fungal sinusitis with possibility of intracranial extension. All of this despite we didn't examine the brain well because it is mainly orbit and the paranasal sinus examination. Our doctor did very well when she asked for post-contrast and follow-up. Okay. After 2 days only, after 2 days, big disaster. What happened? Multifocal hypodense non-enhancing area in both frontal, then here in left frontal, and I think down here posteriorly. Big disaster here and here may represent infarction versus cerebritis. Then the patient underwent MRI to delineate the whole disaster. What happened in MRI? This is T1 fat set. Okay, T1 fat set. What happened? Hyperdensity within the sinuses, the left side, denoting high T1 signal. It means is fungal sinusitis. Why? Because the hyphae of the sinus produce some heavy metal that produce this high T1 signal. So it is very sure sign of fungal sinusitis. After that, you can talk about other finding like thrombosis, like infarctions. Also here you compare this vein with this one, you will be sure about the superior ophthalmic vein thrombosis, and here also. Here is very obvious. Here, don't look in MRI for the vessels in post contrast. Why? Because this is not MRA. Okay, so we only evaluate the soft tissue. Here, the sinus, the cavernous sinus, right sided is enhanced, but the contralateral side completely non-enhanced. So there are thrombosis here and the left superior ophthalmic vein. After that, the case became very easy. Look here also, my colleague. Look, look here. Compare the cavernous sinus at the right side with the left side. There are very, very obvious discrepancy, non-enhancement at the left side. So, and finally, after follow-up, after status post-operative, because this patient diagnosed as a invasive fungal sinusitis, he underwent enucleation of the left eye. However, he, despite a very severe complication in the form of multiple cerebral abscesses. Okay, my colleague, look here, multifocal areas of peripheral enhancement and of a collection or hypodense areas representing fungal abscesses. So finally, it was a invasive fungal sinusitis. Anyone has any question? Because I will switch off this case. Any question, my colleague?
For the globe, I think in the one of the MRI appears irregular.
Coloboma.
There is some
Looks like
collection
coloboma.
outside. Yeah, it looks
Yeah,
like
yeah.
rupture or something.
No. See, in MRI, the globe is distorted. Looks like the AP diameter is elongated. Looks like, okay, maybe rupture. I don't know. And I didn't object, but at least the EP diameter is increased. Looks like colopomic. However, I think in the CT, it is not obvious. Maybe after fungal, you are right. Maybe after fungal sinusitis, some changes occurring. Thank you, doctor. Any question, my colleague? Any
Sir, what will
question?
be the signs of angio-invasive? Uh, what will be the signs
Okay,
of
number one.
angio-invasive?
Thank you, doctor. Number one, direct extension, intracranial or intraorbital. Here in this patient, why is this patient complicated and the doctors can't save him? Because in the first CT, I think it missed. Maybe this one missed this fracture. Besides, there are some very subtle really. If you look here, very subtle fat smudging here. Here. Can you look? You see it or not? This one, doctor. Very subtle.
Yes, sir. Yes. Yes, sir.
This one. And I think it was diagnosed as cellulitis here, periceptal cellulitis. Okay. So early picking up of invasive fungal sinusitis is a life-saving. Okay. The other signs is the hyperdensity here. The hyperdensity here of the of the sinusitis. But really, there are no hyperdensity. At least there are some bone erosion here. And after using MBR, I think you can detect some other finding. So the most common finding, either hyperdensity in CT or bone destruction, invasion to any extra sinus extension, all of these are a sure sign of the invasive pattern of the fungal sinusitis. Besides that, we have one very sure sign here. This thrombosis. This is indicate that we are dealing with a non-benign fungal sinusitis, a very aggressive. Is it clear, doctor? Any other
Yes, sir.
question, my
Yes, sir.
colleague? Any other question? Okay, I will switch off this case. One of the fantastic cases. Dr. Nagam, thank you so much. Really, 9 by 10 at least. Thank you so much. Next
Thank you.
candidate. Welcome. Next candidate.
Hello, doctor.
Welcome, doctor. This is 60-year-old male patient presented after a history, or he has a history of road traffic accident and followed by surgical intervention. Now he is presented with right eye pain.
I'm presented with axial cuts of CT brain non-contrast. I will scroll through the study till the last cut and then start to give my statement. My first thing I noticed is that there is hyperdense soft tissue abnormality seen at the right ear, and the overlying the skull base, extending into the skull base as well. And there is some
Yes.
obliteration of the fat planes and
Yes.
extending to around the carotid sheath.
Yes.
Sorry?
Yes. Yes. Go on.
Hello?
Go on.
Okay. Okay. And there is evidence of bony erosions noted as well. I would like to check the bone window for further assessment.
Yes.
Okay. In the bone window, I noted that there is a sclerosis in the mastoid air cells with erosions. Okay. Okay, involving the petrous bone
Mm.
as well. Doctor, the
Excellent.
image is not scrolling.
Yeah. Okay.
Okay. And there's a sclerosis as well of the sphenoid bone. I'll check the ear structures and the external auditory canal that shows some partial obliteration. I can see that the inner ear structures are intact. I would like to check the middle ear. There is obliteration of the middle ear, yet I still can see the ossicles.
Okay.
Okay, so there is this is outside with a given history that the patient is in a post intervention status. This is likely inflammatory process. I would like to check if there is a contrast enhanced sequence.
No contrast enhancing.
Suspecting that the patient may have post-operative skull base osteomyelitis, and I would recommend further assessment with the MRI scan with contrast. Okay, I'm presented with the axial T2 cuts of the brain. I will scroll through the study and then start my statement. There is a high T2 signal noted at the mastoid and yes. And the around the external auditory canal as well, and there is uh, it's a
Yes.
bit difficult while not scrolling. We're concerning the obliteration of the middle ear. I would like to check the contrast study and to evaluate the any intracranial extension, any abscess formation. Yes, there is extensive enhancement in the skull base. Um, uh, noted is extension to up to the nasopharynx. I would like to look at the carotid artery. It does show a filling defect that could be a complication of the condition with carotid artery partial occlusion. still I cannot see a definite localized fluid collection. So the yes, there is as well. There is a right-sided fluid collection. I see it. Yes. Um, so this patient needs urgent referral. Yes, at this cut. Yes, there is a fluid collection with the ring enhancement. So the patient will need urgent referral to the neurosurgery team for further drainage of this collection that shows ring enhancement with non-enhancing center. I would like to check the brain for any intracranial complications. Well, there is infratemporal meningeal enhancement that could be related meningitis. Yet I cannot see any intracranial space-occupying ring enhancing lesion to denote any abscess formation. I would like to check the cavernous sinus. And the brain sinuses if there is thrombosis as well. I can see the superior sagittal sinus is patent. The orbit, I cannot see any problem in the orbits are unremarkable. Yes. So this case needs urgent referral to the neurosurgical and head and neck specialties for further surgical drainage of the collection and extensive antibiotic therapy.
Thank you, Doctor, really so much. Thank you so much. It was very difficult case, but you pick up most of the finding. What happened here, my colleague? Doctor, I'd like to ask you one question. Which history you wanted to ask the patient about?
Maybe cranial nerve affection.
Mm.
And maybe details about the surgery he has done. Nothing else in my mind.
What else?
Hello.
There are very important
The
history.
patient in his history, in the history, it's mentioned that the patient has diabetes. So maybe ask about if the patient immunocompromised in any form, treated for taking any immunosuppressive therapy.
This is correct. Very important to ask. Why? Because this is regular patient just have an operation and they presented with this extensive skull base osteomyelitis are very unusual. So in any atypical scenarios like this, you must ask about any history of immunocompromisation. That is correct? Okay?
Yes, sure, doctor.
Okay. What do you think?
Thank you.
Is this patient have something also you didn't comment?
There is a extension in the CB angle, maybe.
What else? What else?
Don't know. The carotid artery, I commented on it.
See, this patient has ET tube. You didn't
okay.
talk about it at all. Thank you, doctor, so much. This is the ET tube. This means
Okay.
the patient is very critical. What happened here, my
Yes.
colleague? It was a case of skull-based osteomyelitis. Why I bring this case? Because very rare to see osteomyelitis and very aggressive, very aggressive osteomyelitis like this in the skull base. This patient is post-traumatic and underwent a surgery. After the surgery, look, aggressive, severe, right-sided, look here, right-sided soft tissue infiltrating the area of the right ear, petrous bone. So you did very well when you asked for the bone window, and she started describing the skull base, petrous bone. All of us is a non-familiar area for all of us. So I will show you the normal anatomy after the next case. What happened here? There are destruction here. This is the clevius. This is the clavio or the petroclevius region destructed, and this is all this area. Look at the other side and start to describe what happened here. What happened here, my colleague? This is the carotid canal. Almost erosion of the carotid canal here. Look here. The carotid canal distracted here. And this is very, very dangerous. And what else? Sclerosis here of this bone. What is the name of this bone? This is petrous bone, this one. This is squamous part of temporal bone. Okay? This one, I think this is part of the sphenoid. Why? Because the sphenoid, this is sphenoid bone. Yes. And if you look here, you can't detect even the foramina here. The skull base foramina here is completely distracted in comparison to the contralateral side. Like this is the foramen ovale. I think here no foramen ovale. And just posterior to the lateral is the foramen spinosum. Okay? Here you can't detect any of them. Our doctor asked for this post contrast. Okay? What happened here? What happened? Large enhanced soft tissue, okay, with collection inside it. What does it represent? The severe inflammatory changes. Somebody may ask, doctor, it may be a tumoral. Very difficult. Why? The tumor is not diffuse like this, and the tumor must form a mass, localized mass, more than diffuse tissue inflammation and enhancement like. So the final diagnosis was skull base osteomyelitis. Thank you, doctor, so much. Next candidate.
Yes, sir.
Okay. This patient, a 60-year-old male patient, presented with headache, blurred vision, diplopia, right-sided facial, and tongue numbness.
Yes, sir. I'm
Can you
presenting.
request the mouse?
Yes, sir.
Try to use this toolbar, please. Yes, thank you.
Okay. I'm presented with axial non-contrast CT for 60 years old male presented with numbness, swelling, and diplopia.
Yes.
I first go through top to bottom and then present my findings. Okay. I cannot see any gross intracranial infarction, hemorrhage, or midline shift. The orbits appear unremarkable preseptal and postseptal compartment. However, I can see some distension of the right cavernous sinus. There is asymmetry between the two cavernous sinuses.
Yes.
The ethmoid sinuses are normal.
Yes.
Maxillary sinuses are also normal. I cannot see any cerebellar lesion. Brainstem is grossly unremarkable. And the soft tissues of the neck are also normal. The finding which I have noticed is the asymmetry between the cavernous sinuses, and I would like to review that on contrast imaging to see any filling defect within the cavernous sinus.
So I can also see some air foci within the right cavernous sinus. There are
What
some
area?
air foci within the right and
Don't worry
near the
about
bone
the
erosion.
cavernous sinus. Don't worry about it.
Okay. Okay. Apart from that, the both carotid canals appear unremarkable. The mastoidations are
Sorry,
normal.
where is your concern in this? Sorry, right or left cavernous sinus?
So firstly, I saw the distension of the left cavernous sinus, but
No,
then
don't
the
worry
air
about the
foci.
left. Don't worry about
Okay,
the
but
left.
the air foci within the right cavernous sinus are concerning for some bone erosion. I would like to see that on bone window. Can I see the bone window, sir?
Okay, before watching the bone window, uh, have another look.
Okay. I would like to see my review areas.
Yes.
There is no crowding at foramen magnum. The prevertebral muscles are normal, and I cannot see any hyperdensity within the visualized venous sinuses. Middle ear cavities appear normal.
Yes.
There is some hypodensity of the brainstem, but this may be artifactual in this region.
What else?
Orbits are grossly unremarkable. I would like to see superior ophthalmic vein.
Don't worry about it. Look at the skull base, please. Region of skull
Okay.
base. What happened?
The skull base. Up till now, there is symmetry between the soft tissues. Both pterygoid plates, the prevertebral muscles. The nasopharyngeal muscles and the. So can I see the bone window?
Stop here. Okay. See the bone
Here?
window. Okay. See the bone window.
So in the bone window, I can see that there is some erosion and widening of the foramen lacerum and carotid canal, and this sphenopalatine foramen. This one is widened and erosion, and there is some widening of the pterygopalatine fossa on
Okay.
the right side with some
Okay.
erosions, and there is the lateral
Yes.
wall of the carotid canal is also eroded.
Yes.
And can I scroll, or this is static
Yeah.
image?
No. Scroll upon.
Okay. Okay. And as I go down, yes, the both carotid canals are preserved, and jugular foramen is okay. Hypoglossal canal is okay. Basisphenoid and clivus is okay. So the main abnormality is here at the level of the foramen lacerum, the horizontal part of carotid canal, and sphenopalatine foramen leading into pterygopalatine fossa, which has some widening and some irregular erosions. I would like to see the foramen ovale and less. I cannot see these two foramen ovale and spinosum on the right side as well.
So what do you think?
So there is, I cannot see any gross sclerosis to suggest osteomyelitis, but this is some infiltrative aggressive process involving the skull base, which may be infective or neoplastic. And I would like to further relate this with contrast study or MRI for further evaluation of the and exact characterization of
Leave the
this
mouse.
abnormality.
Leave the
Okay.
mouse. Which sequence do you want? Take this one.
Okay.
Go on.
In axial flare,
Yes.
I can see some asymmetry between the soft tissues of the nasopharynx on the right side. Sir, I cannot scroll. Okay. And there is some hyperintensities within the soft tissues of the skull base in the expected position of the foramen lacerum and carotid canal as seen previously on CT. However, no definitive mass is seen
Are you
now.
sure?
And
Are you sure? No definitive mass?
I do not see any mass effect here. There is just asymmetry and signal abnormality involving the
Yes.
soft tissues.
So what do you think?
So it can be nasopharyngeal carcinoma,
Okay.
and it can be skull again, some skull base infiltrative process, or it can be any primary bone tumor or metastasis involving the skull base.
Leave the
I
mouse
cannot
1
see
second.
any.
Hmm.
Okay,
What happened
so
here?
this is control. So can I scroll? Okay. On contrast enhanced imaging, I would like to go from front bottom. There is intense enhancement of the nasopharyngeal soft tissues, which is extending into the cavernous sinus as well,
So
and
what's your
into
final
the
diagnosis?
So my final diagnosis is nasopharyngeal. It can be squamous cell carcinoma or any malignant etiology involving the nasopharynx and extending intracranially and involving the carotid canal. The other possibility can be some infective process which is involving the
What is the
skull
name?
base and
What is the
extend.
name of the first processor that you just described now?
What is the name of
Nasopharyngeal mass.
first?
You just described a
Uh,
nasopharyngeal mass that extend into the
mm,
cavernous sign. What is the name of this process?
Intracranial extension.
Yes. What is the means of extension here?
The mean of extension here is, sir, foramen rotundum.
Yeah.
And
So
yeah,
how can you call this means of
Perineural,
trans? Yeah, excellent. So
perineural spread of the
thank you,
tumor
doctor, so much.
from
Thank
the
you,
skull
doctor,
base.
so much.
Yes.
Thank you so much. Nasopharyngeal carcinoma with perineural spread. What happened here, my colleague? When the examiner give you any sequence, almost 99% this sequence have many findings. Squeeze the sequence till the end. Here, if you look here, see, there are some soft tissue here, or at least asymmetry between this cavernous sinus and here. Even the bone in the left side, here not seen. So there are some distractions. So go up and down around this lesion. Even this is non-contrast. If you look here, here more hyperdense than here. Go down. Hello?
Yes, sir. Yes, sir.
1 second. Go down and up around the area of concern to pick up more and more finding. Leave the mouse, doctor, please.
Okay, sir.
Sorry. If you go down, go. There are here soft tissue, convex border with convex border at this area. Go down, 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 down. Here you will pick up some asymmetry. Look here, what is this? Some asymmetry, and this is
Mhm.
the beginning. The nasopharyngeal carcinoma start like asymmetry like this. Okay. If
Yes,
you
sir.
change to the bone window, you will get more and more information. Very obvious destruction to the right side. What happened here? Take the tragoid as a landmark for you. This is the tragoid. And go up and down from it. If you look here, compare this side with this side. Compare this with this. There are widening or erosion of the bony boundary here. Okay? What is the name of this bony boundary? This is the tragoid. Okay? So there are fissure and there are fossa here. Tergo maxillary fissure and then fossa. There are widening here due to soft tissue. If you go up and down, you will see here this foramen is not healthy like this. There are some erosion and widening. If you go down, this is foramen rotundum, oval. Here, almost distracted. And by the way, this is through the foramen oval. Which nerve running through the foramen oval, doctor? Do you remember?
So V3,
No.
third mandibular division of the
Mandibular, yes,
trigeminal.
V3.
Yes,
So,
yes.
so what happened here? Almost the tumor of the nasopharynx, okay? Use the mandibular nerve to spread into intracranially to the cavernous sinus. Okay? And this is,
Okay,
it
sir.
was a case of nasopharyngeal carcinoma, very obvious in coronal here. Look here. Look. Here, very obvious mass. What happened? Enter
Extend
the
through.
cranium through the foramen oval by a perennial means of spreading. Okay, look here,
All right, sir. Thank you, sir.
very thick here, and distracting the calforamina. Look here, this is not acceptable to be a normal asymmetry. Tumors start like this, my colleagues, like subtle signal abnormality, as or soft tissue asymmetry. Look here. This is the tongue. So we are at the level of oropharynx. Go up, 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 up. After the hard palate, you are in the nasopharynx. If you look here, there are enhancing soft tissue here. Very mild asymmetry. Okay? Very mild.
Yes, sir. Yes, sir. Yes, sir.
Okay. Thank you, doctor, so much.
Thank you,
I
sir.
know my
Very nice case.
colleague
Thank you, sir.
skull base is one of the very, very unpleasant area for all of us, but we must study it. Look here, it is very obvious. This is the carotid, this is the cavernous, and there are soft tissue here. Thank you, doctor, so much. Next
Thank you,
second,
sir.
before next second, look here, my colleague. What happened? This is the tragoid. In skull base, you can start from any landmark. Somebody wanted to start from foramen oval as a landmark. He will compare right, left with right. This is the left side. Okay. And this is the carotid canal, just posterior to the foramen oval. This one, and this one. Okay. Where is the foramen rotundum? This one. Right, left and right. The most difficult part for all of us, the part of the tragoid. But one by one, this is the tragoid itself. Has a lateral and medial tragoid. This is the right, this is the left. Tragoid has two parts. Okay, has fissure pterygomaxillary fissure, which is at the door of this part. The beginning is the fissure, and the space itself is the fossa itself. Okay, pterygopalatine fossa. Even me, I confused between both of them, but at least I know this is the fissure and this is the fossa. Okay, at least we must know the foramen ovale is this oval one. Posterior to it, the foramen spinosum. Posterior and lateral. Anterior and just medial, foramen rotundum. Okay. Then at the orbit, this is the optic nerve. So this is the optic canal bilaterally. If you go up, this is the superior orbital fissure. If you go down, below, an opening below the optic canal. This one, the inferior orbital fissure. At least try to know as much as possible structure in the skull base. Posteriorly, this is the clivus. Okay. At a certain point, this is the petrous. There are a fissure or synostosis between the clivus and the petrous called Calvarian or clivus, whatever fissure or synostosis. This one, okay? If you go down, 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 this is where is the axis? This is the tip of the axis. Okay, so this is C1. I know it is very difficult in Excel. This is C1. Okay. If you go up, 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 this is the foramen magnum. So this is the boss condyle of foramen magnum. I know it is non-familiar and difficult, but we must know the minimum about the skull. Okay, my colleagues. This is the carotid. Posterior to it, this is the jugular. Between both of them, carotid and jugular, there are this one, bony septum. It is very important because you can diagnose with this septum many diseases. Okay, my colleagues, very important. Next case, next candidate.
Yes, sir.
This is, I think, more easy case than before. 65-year-old female patient presented with intermittent progressive headache with subacute facial drop. Go on.
Yes, sir. So I have been presented with axial CT images of a brain
Yes.
of a patient who is presented with a complaint of headache, and so I will have a quick look through the whole set of the images before I comment my finding. Okay, so I can see there is evidence of one restrictive area or noted in the region of the right hemispheroid air cells involving the right jugular fossa, also extending into the inner ear appears normal. I'm looking at the middle ear cavity also appears normal.
Yes.
So this stone seems to be lie predominantly at the region of the jugular fossa, causing adjacent bone distraction with the carotid canal appears on that side appears normal. So in this, I'm thinking of a lesion within the jugular fossa with
with the adjacent bone restriction. So I'm thinking of in terms of glomeus jugular tumor, I would like to have a soft tissue window or post-contrast images of this patient if available.
Leave the notes. Leave 1 second. Go on.
So these are the axial CT images of a SAM patient. I will have. So I'm going to the SAM area of concern. I can see there is a soft tissue mass lesion lie at the jugular fossa. So with a significant bone destruction, and there is no the base of the foramen magnum appears normal, no crowding is seen, or no extension into the inner ear or the medial cavity. So I'm thinking of a glomeus jugular tumor. I will convey my finding to the referring physician and ask for MRI images of this patient if available, and also if patient have history of tinnitus, pulsatile tinnitus.
Time out.
However, this is more okay. So these are the axial T2 MRI images of the same patient. I will go into the area of concern. So here, this is again a demonstration of the mass lesion at this area. With there are multiple signal voids area are also seen, which is again in a favor of a tumor like a paraganglioma, which is involving the jugular fossa. There is also evidence of mastocytitis seen on the right side. So I'm looking at the inner ear appears again normal. I'm looking at the medial cavity. I think this is medial cavity appears normal. I will also would like to see the MR venography images of this patient if available to see jugular dilatations and jugular vein dilatation, and I will convey my finding to the referring physician, refer this patient to the.
Leave the mouse. Leave.
Yes, sir.
This is the venography. What do you think?
So these are the venography images of the same patient, and which is showing again expansion of the jugular. Can I scroll?
Yeah.
Yes, sir. So I again can see the expansion of the jugular sinus with so yes, there's again expansion of the jugular sinuses at this area. So this is again a confirm a finding of jugular sinus paraganglioma. So I will immediately convey my finding to the referring physician, refer this patient to the ENT for further management. Also, in my routine practice, I will also look for other paraganglioma if available in the body to rule out any syndromic association in these patients.
What's the other differential diagnosis? You mentioned this is what type of paraganglioma, please?
Or jugular paraganglioma, as I could not find extension to middle ear cavity.
Okay. What other differential diagnosis?
Other differential diagnosis for this could be a schwannoma at this area, but least likely because I could.
I mean, why doesn't you consider it as another types of paraganglioma like carotid body tumor? Why?
Okay, because I can say it is mainly lie at the jugular fossa, and the MR venography I saw the
Okay.
MR venography I saw the dilation of the
Could
jugular.
the lesion be glomus tympanicum?
Also, I could not find extension in a middle ear cavity. This is the inner ear.
Yes or no?
I think no.
No. Okay. Okay. Why does this lesion not show an OMA? Do you have any clue or suggestive
Yes, sir.
sign? What?
Yes, sir. I saw a signal void area
Where?
in this lesion
Where?
on the T2 I think on the T2
This is
images.
T2? Where?
Sir, yeah, what is area?
Yeah.
There
Thank
are
you,
multiple
Doctor,
signal
so
voids are
much.
seen.
You fulfill most of the findings, but you must tell the examiner. Doctor, my top of differential diagnosis is glomus jugular. However, it is not possible to consider it as a carotid body tumor because 1, 2, 3, the level, and it is not extending to the middle ear, so I can't also put the glomus tympanicum in my differential diagnosis. How can we get up the level of the ear? In T2, in MRI, it is very difficult, but very easy method, my colleague. Either by the nerve, because here this is IAM, internal auditory meatus, or by the labyrinth. Okay, it will be seen very well in T2. So here is the level of ear. So by location or by expectation, it should be this is the middle ear, and this is even by the external ear. So many signs. Where is the lesion? The lesion is at lower level. At lower level. Why? Because the nerve is here, the labyrinth is here, so we can't detect any lesion. We must go down many slides. Down the lesion start below the ear level. Thank you, doctor, so much. Next candidate. By
Hello.
the way, this is the answer. It was tympanicum paraganglioma. But I think in the description, they didn't mention anything about just erosion of the posterior wall of the petrous. But no true extension into the middle ear or the ear itself. In my opinion, if you mention, okay, if you told the examiner it is mainly jugular paraganglioma, I think it is very good answer. Okay, my colleague. Somebody is asking, Doctor, why there are many finding here in the Radiopedia that our colleague didn't mention. Yes, because see, in the viva exam, this is not a typical reporting case. The examiner wanted to assess your knowledge, your answer, your communication skill. Okay, your differential diagnosis, your next skill. So almost within 5 minutes, it is impossible. So almost you are giving the main routes, main items, especially critical science. And I think our colleague mentioned as much as possible related science. Okay. If you wanted to do a report like this, give her a workstation and give her at least 1 hour. Thank you, doctor, so much. Next candidate.
Hello.
Hello.
Hi.
Hello.
Sorry, can you... Hello?
No, doctor, your voice is very muffled.
Okay, sorry. Can you hear me now?
No. Very muffled. Hello?
Hello?
Doctor, can you change your connection? We will take candidate 6 until you repair your connection. Candidate 6, please.
Is it better,
Candidate
sir?
6? No. Your voice is not clear at all. Dr. Nagam, next candidate until candidate 5 repair her connectivity problem. Hello?
Okay, candidate 6, please proceed.
Hello?
Yes.
Yeah, candidate
Yes,
6.
Dr. Rami. You
This voice problem from my side, Dr. Nagam, or your side?
yes, yes, because candidate
I
5
think in the
voice was
chat
clear.
you can hear me. Yeah.
1 second, this connectivity problem is from my side or your side?
I think so, because we can hear candidate 5.
Yeah, 1 second. Give me 1 second. I will change the connectivity.
Okay.
Candidate 6, this is a 65-year-old male patient presented with left eye vision loss, pain, proptosis. He has a non-control, I think this one, sorry. This is a
Okay.
6-year-old female patient presented with severe 7 weeks history of right-sided otalgia and hearing loss.
Okay, this is axial CC brain or maybe petrous spoon bone window. I will just scroll through the whole scan before giving my comment. The first striking abnormality I could see is there's some bony erosion along the right external auditory canal. Okay, with some soft tissue within the canal as well, causing erosion of the posterior part of petrous spoon and
Yes.
okay, just looking for the extension. It extends. Okay.
Look here, it is very
Okay, so soft tissue density appears to be expanding the external auditory canal, extending into the middle ear cavity as well. I will try to check the scutum and the ossicles erosion. The ossicles appear to be eroded, and it appears to involve the inferior part of temporal bone as well. However, the semicircular canals appear intact, no dehiscence. In my routine practice, I would look at the soft tissue window as well. And maybe if the patient is still in the hospital, I would proceed with contrast or better to do MRI with contrast.
okay.
Because I'm suspecting aggressive process of the external auditory canal.
Yes.
Okay, this is coronal T2 of the same patient. I'll go to the area of interest. Yes, the brain appears grossly, I think, unremarkable. However, I cannot see the uppercuts. Okay, so the soft tissue edema and soft tissue mass is seen within the right extremity canal, extending below along the sternomastoid trapezius muscle. It's posterior, so trapezius muscle. Okay, in my routine practice, because it seems to extend superiorly in the base of the brain across the skull base, so I would be worried about brain affection as well. So I would assess the brain with a dedicated study post contrast.
Okay, but we have only post contrast, head and neck. What do you think? Or petrous? What do you think?
Okay, at the site of involvement, there appears to be some meningeal enhancement. The right side.
No meningeal enhancement. No
Okay.
meningeal enhancement. So, where is your concern, doctor?
In the right external auditory canal extending into the middle ear and involving of the ossicles.
What do you think?
So it could be it's aggressive lesion, so either infection or malignancy. But my first differential will be malignant lesion in the external auditory canal, maybe squamous cell carcinoma.
Yes. So,
In my routine practice, I would convey my findings to a referring physician and ask for biopsy of this lesion, and I would do CT chest abdominal pelvis for further staging.
Patient refused to do biopsy, and after 4 months, come again for CT. What do you think?
So the aggressive lesion appears to be there's more aggressive features now with bone erosion across the jugular fossa and the buttress bone on the right side. Okay.
And what is this?
Um,
What is the name of this system?
this is the jugular foramen.
No, the jugular is this one. Okay,
Okay.
this one. Okay, but
Yes.
I'm asking about more anterior, this one. There are erosion here. What is this?
It's a lower level, I think, so maybe the hypoglossal canal. I'm not sure.
It's the occipital bone, anterior part.
Yes, okay.
Okay,
Okay.
okay. Where is the hypoglossal gland? Where? Hmm. This one.
Yes, okay.
So, what do you think?
Yeah, I'm more convinced it's a malignant mass invading the skull base and maybe extending into the brain.
Yes.
So I would do. So yes, this is MRI of the brain T1.
You previously comment on it. I think they did another MRI after 4 months. What do you think?
So there's this is axial T2 MRI appears to be area of high signal intensity within the right external auditory canal. A large soft tissue lesion was appears to be heterogeneous with areas of cystic and solid component within the right external auditory canal. I'll try to assess the extension. The vertebral artery appears to be sigmoid. Yeah, the soft tissue lesion appears to invade the occipital bone. They're on the right side. And
which
yes.
structure you are very worried about it?
The nerves.
What else? Look
and
at the mass first.
So the carotid artery.
What?
However. So in the region of the occipital bone.
What is this? What is the name of this structure? Which is markedly compressed or maybe infiltrated?
Can you show me again, sir, please?
This one.
Which one you're talking about? Yeah, this one. Yeah, this is the jugular.
Yes.
The sigmoid sinus and the jugular vein. Yeah.
Yes. Maybe infiltrated. And look here
Okay.
at the aorta. What happened for the aorta? Sorry, for the ICA.
It appears to be narrowed.
Hazed.
Yes.
So maybe a sign of invasion. A sign of invasion. So what's your final diagnosis?
So malignant mass in the but its main bulk in the external auditory canal. I would be worried about the squamous cell carcinoma with invasion of the skull base, internal carotid artery, right internal carotid artery invasion, and sigmoidal sinus invasion as well. So I would be my next step would be doing MR venography to assess the sinuses, maybe angiography as well to assess the arteries.
Yeah, okay. Okay, thank you, doctor, so much. It was external ear canal squamous cell carcinoma. What happened? The examiner gave you CT and bone window. Very atypical scenario. When you are looking here, compare. See the bone here, convex, but here eroded. Very important. Okay? And
yes,
if you follow the external canal here, because it is confusing, in comparing with the other side, you will see something here eroding this bone, and look here, abutting the ossicles. Erosion. The most striking abnormality here is erosion. I think here in coronal more obvious. Why? Because there are air here. So this is the normal soft tissue. But if you look here, it is obliterated, no air. See, no air. Beside that, there are obvious bone erosion, either to the floor or to the roof, and even to the ossicle. Okay? Look here, everywhere. So you ask for MRI. Let's see the most obvious MRI here, because this is after 4 months. If you look here, this is soft tissue mass enhancing. Become very obvious. The mistake, I think, this patient either the radiologist missed the report in his first report, this mass to warn about it. So the patient wait for 4 months, or the patient, I didn't think the patient refused to take biopsy. Look here, the mass is very large. I think يعني about near subtotally surrounding the ICA. And here markedly compressing the jugular and the pulp and sigmoid. Okay. Indentation of the vessel in this style may be a sign of infiltration. There are many signs of infiltration, like in the chest, if any tumor surrounding a vessel more than 90 degree, it is a sign of infiltration. In the abdomen, more than 180. In the brain, I think this is or severe indentation or compression like this. So you were very correct when you asked for MR vinography, but this is, I think it is more than enough. Okay, more than enough. This study, this is axial post contrast, but it delineate very obviously the veins and the jugular and the sigmoid. I think here, if you talk about this meningeal enhancement, okay, here in this slide, this is okay, true meningeal enhancement. Okay, thank you, doctor, so much. It was
Thank you.
external ear squamous cell carcinoma. I think more than enough today, many difficult cases. Let's continue our journey next Wednesday. Thank you so much for all of you.
Okay, thank you, sir.
Thank you.